Hi guys, this is Dr. Patil, and in this video we will be discussing systemic sclerosis. When it comes to NEET super specialty, this is one of the very important topics, and there are two or three important areas to focus upon. The area number one is differentiation between limited cutaneous and systemic, the diffuse cutaneous. Right? That is one area. A lot of MCQs have appeared from this. The area number two is to differentiate between various autoantibodies and their clinical associations. Which autoantibody is associated with malignancy risk? Which autoantibody in systemic sclerosis is associated with the risk of developing interstitial lung disease? Which autoantibody is associated with the diffuse cutaneous version, or which one is associated with limited cutaneous? This is one area to focus upon. And the third area to focus upon is the particular complications like interstitial lung disease and scleroderma renal crisis. These are very important areas to focus upon. Okay, so let us start the topic now. Systemic sclerosis is a multi-system disorder characterized by three important features. What are those important features? Small vessel vasculopathy, organ fibrosis. When I say organ fibrosis, that means involvement of skin plus other organs, right? Plus other organs. And the third important feature is presence of specific autoantibodies. When all these occur together, we call it a systemic sclerosis. Because we have various other disorders where there may be organ fibrosis, multiple organ fibrosis. There are various disorders where there may be skin thickening or skin fibrosis. When all these occur together, we call it as systemic sclerosis. I will give you an example. We know something known as nephrogenic systemic fibrosis, right? Nephrogenic systemic fibrosis, which is a complication of gadolinium contrast exposure to a patient who already has a compromised kidney functions. So there also there is skin thickening, there is skin fibrosis, there is also internal organ fibrosis like the lungs and peritoneum, right? That is why we call it as nephrogenic systemic fibrosis. But it is not considered as systemic sclerosis because we don't see autoantibodies there, right? We don't see specific autoantibodies there. So remember, we will call it as systemic sclerosis when there is skin plus other organ involvement and plus there is specific autoantibodies present. Okay, that is the basic intro. Now let us understand the risk factors. What are the risk factors for someone to develop systemic sclerosis? When we talk about various other autoimmune disorders, we generally talk a lot about the genetic factors, but when it comes to systemic sclerosis, the contribution from the genetics is minimal. Contribution from the genetics is minimal. So remember, only 1.6% of the patients generally have a family history or a first degree relative of systemic sclerosis. First degree relative or family history. So in remainder cases, there is no evidence of the involvement of a family member. Right? What does that mean? That means there is probably environmental factors play more important role in the pathogenesis than the genetic factors. But nonetheless, genetic factors are also still important for us to know, because 1.6% might seem a small number, but if you take into account the overall prevalence of systemic sclerosis, this number starts making a lot more sense. Okay. Now, what points we should remember from the exam's perspective? The first point I want you to remember is HLA-DRB1. Yes, the antibody, the HLA variant that is classically associated with various other autoimmune disorders like rheumatoid arthritis and SLE. Yes, that can be seen in patients with systemic sclerosis also, and its presence correlates with the scleroderma renal crisis risk. Scleroderma renal crisis risk. Okay. Apart from that, there are certain non-HLA genes which are also associated with higher risk of developing the systemic sclerosis, and that includes two classical examples, STAT4 and PTPN22. You guys are very much familiar with these two genetic loci because they are associated with various other autoimmune disorders. It is not specific to systemic sclerosis, right? Presence of these increases the risk of developing scleroderma. Okay. Another point I want you to remember about TNIP1 gene. Right? Certain polymorphisms in this gene are associated with increased risk of developing isolated pulmonary arterial hypertension. Isolated pulmonary arterial hypertension. Right? That's about genetics. I think if we know this much, it's more than enough. Right. Now coming to the environmental factors, we clearly know that they play an important role. So let us dissect them one by one. The first thing you should know is about the role of silica. Silica, being an immunoadjuvant, right, plays an important role in the pathogenesis of various autoimmune disorders, including rheumatoid arthritis, SLE, and it holds good even for systemic sclerosis, right? So silica exposure is considered as a risk factor for development of systemic sclerosis. Other than that, occupational exposure to certain epoxy resins, polyvinyl chloride and aromatic hydrocarbons. Mostly people get exposed to these substances at their workplace, right? Occupational exposure is associated with heightened risk of developing scleroderma. Okay. Silica, epoxy resins, polyvinyl chloride and aromatic hydrocarbons. Okay. Other than that, yes, drugs are also been implicated. That includes bleomycin, cocaine, cisplatin, and also appetite suppressants, mainly the one that is not currently used, fenfluramine. These drugs have been implicated in the pathogenesis of systemic sclerosis. And also there are some associations with infections for us to remember. CMV has been implicated, Epstein-Barr virus has been implicated, and then one particular bacteria known as Rhodotrula glutenis. Difficult to pronounce. Rhodotrula glutenis. This has also been implicated in the pathogenesis. Okay. So that is about the environmental factors. So what we understand so far, genetics plays a minor role and the environmental factors play an important role. What cements our understanding of the importance of environmental factors is that there are certain disorders which we can call them as scleroderma mimics or scleroderma-like illnesses. These are the examples: toxic oil syndrome, eosinophilia myalgia syndrome, and nephrogenic systemic fibrosis. These are illnesses which are usually triggered by exposure to certain toxic substances, and they literally mimic the scleroderma. Clinical presentation is very much similar to systemic sclerosis. Right. So that goes on to re-emphasize the importance of environmental factors in the pathogenesis of systemic sclerosis. Right. So let us see some of them. The first one is toxic oil syndrome. Right. So in 1980s, there was an epidemic of scleroderma-like illness in Spain and certain related countries, where later it was traced to the fact that contamination of the cooking oil by rapeseed oil. Contamination of the cooking oil by rapeseed oil was responsible for that epidemic. It just goes on to say environmental factors play more important role. Right. Similarly, contamination of dietary supplements with L-tryptophan was responsible for another scleroderma mimic known as eosinophilia myalgia syndrome. Okay. The third thing that I have listed here, nephrogenic systemic fibrosis, you are very much familiar with, right? It is a scleroderma-like illness triggered by gadolinium exposure, right? Gadolinium contrast exposure in patients with CKD, or I can say compromised kidney functions, right? So these are the illnesses which mimic the scleroderma, and generally they are associated with exposure to certain toxins. Right? Rapeseed oil for toxic oil syndrome, L-tryptophan for eosinophilia myalgia syndrome, and gadolinium for nephrogenic systemic fibrosis. Now coming to pathogenesis, if we have to talk about pathogenesis, I want you to remember one particular point, right? The central pathogenetic mechanism is basically vascular injury. And the fibrosis is an outcome of vascular injury. So it all starts with vascular injury and then ends with fibrosis. Okay. What triggers vascular injury? Yes, so far we know what are the environmental factors which are associated. So various environmental factors are associated. Probably there is some degree of genetic involvement. Eventually it is beginning with vascular injury. The cascade of events that are leading to vascular injury are not well known as of now. Right. So we know vascular injury is occurring, but how those environmental factors or how those genetic risk factors are actually triggering the vascular injury is not well known as of now. Okay. So let us start with the vascular injury as our initial point. What happens once there is vascular injury? There is activation of the endothelial cells. Once there is endothelial cell activation, that leads to impaired fibrinolysis, intravascular coagulation, platelet activation. Once there is platelet activation, it produces platelet-derived growth factor, right? One of the cytokine which stimulates the fibrotic process. Definitely stimulates the cell division and also stimulates fibrotic process. Platelet-derived growth factor and endothelin-1, right? All these events lead to leukocyte activation. So there is both activation of T cells in the form of Th2 response and also activation of B cells. Once the B cells are activated, that leads to antibody production. So we have certain characteristic antibodies that are seen in these patients. And once there is antibody production, exactly how it contributes to vascular injury, we don't know. But we know that certain antibodies are associated with certain clinical outcomes. We will be discussing more about it, but right now, remember, antibodies may have some role in the pathogenesis, but right now we have no clarity on it. Okay. Now, the other thing that happens when there is vascular injury is obliterative vasculopathy. So, all these impaired fibrinolysis, intravascular coagulation, platelet activation leads to obliterative vasculopathy. Right? And this obliterative vasculopathy eventually leads to tissue hypoxia. Right? And in response to tissue hypoxia, the cell starts producing fibrogenic cytokines. Right? So, these activated T cells, B cells, and in response to hypoxia, there is production of fibrogenic cytokines. Right? There is production of fibrogenic cytokines. What these cytokines do? These cytokines basically activate the fibroblasts, right? They cause the activation of fibroblasts, and once the fibroblasts are activated, they lead to fibrosis, tissue fibrosis, right? Now, I want you to remember one particular point. TGF beta, right? Transforming growth factor beta is the most important cytokine in the pathogenesis of systemic sclerosis. Yet when we talk about other disorders, for example, if I talk about rheumatoid arthritis, what is the most important cytokine? TNF alpha, right? So always remember these important cytokines for all the disorders, because treatment may be targeting those cytokines, or those may be the new areas of interest for development of newer drugs, right? So when it comes to systemic sclerosis, it is transforming growth factor beta. Other fibrogenic cytokines include interleukin-13 and platelet-derived growth factors, right? So this is the pathophysiology. Why I am stressing upon this is, if you remember that we are starting with vascular injury, and then there are a cascade of events leading to fibrotic response. We can also understand the differences between the limited cutaneous and diffuse cutaneous. How do we apply this principle? Well, we will discuss as we go along. Okay. Now, coming to the spectrum of the disease. On the very mild end of the disease, we have something known as morphea. What is morphea? Morphea, there is patchy skin involvement without systemic features. So, the internal organ involvement or systemic manifestations are not there. Classically, we don't call it as systemic sclerosis. We will call something as systemic sclerosis when there is skin involvement and there are systemic features. Then we call it a systemic sclerosis. But this has a similar pathophysiological process, right? That is why we are discussing as part of the spectrum. So, on the very milder end, we have morphea. Right? We have morphea. What do we see in morphea? We see patchy involvement of the skin. So there is skin fibrosis or thickening, patchy distribution without the systemic involvement. Sometimes it can be linear. The involvement need not be patchy always. Sometimes it can be linear. Then we call it as linear morphea. Okay. When the entity involves both skin and systemic features, then we call it as systemic sclerosis, right? Then we call it as systemic sclerosis. And the systemic sclerosis can be divided into two broad groups: limited cutaneous subtype and diffuse cutaneous subtype. Now, when we say limited cutaneous and diffuse cutaneous, there is always a misconception among students to believe that limited cutaneous means it is restricted to skin, and diffuse cutaneous means it is involving the other organs, which is false. When it is restricted to skin, we call it as morphea. So this limited versus diffuse is basically about the extent of skin involvement. Systemic involvement is the norm in case of systemic sclerosis, right? That is why we call it as systemic sclerosis. So in limited cutaneous, I want you to remember one point. The fibrotic process or the skin thickening actually starts in the distal most parts. So the first affected organs are usually the fingers of upper limbs, right? Fingers of the hands. From there, it spreads proximally, right? So as long as the skin involvement is restricted to the distal portions distal to elbow, we call it as limited cutaneous in case of upper limb. If you talk about lower limb, yes, as long as the skin fibrosis or thickening is restricted to portion distal to knee joint, we call it as limited cutaneous, right? So in limited cutaneous, the fibrotic process is restricted to hands and arm. It is not exceeding proximal to the elbow joint. The lower limb, it is not extending proximal to the beyond knee joint, right? Extending proximal to knee joint. Face involvement is known to occur in both types, right? Face involvement is known to occur in both types. So in limited cutaneous, it is restricted to elbow or knee joint, not proximal to that, right? And the trunk is not involved, right? There is no involvement of the trunk. Face can be involved, yes. Face can be involved. In case of diffuse cutaneous, right, the skin thickening or extent of skin involvement is usually more proximal to the elbow or knee joint, right? Definitely it starts distally, so hand and arm is involved, but it extends more proximally. Then we call it as diffuse cutaneous, right? It is extending proximal to knee or elbow joint. Then we call it as diffuse cutaneous, and involvement of trunk is also feature of diffuse cutaneous. Face to involved hai, face is definitely involved, trunk is also involved, right? So face is involved, then it is extending more proximal to knee and elbow, and there is involvement of trunk. Then we call it as diffuse cutaneous systemic sclerosis, right? Okay, now coming to the autoantibodies that we see in patients with systemic sclerosis, because in the very beginning of the session we did agree that presence of autoantibodies is one of the integral component of the concept of systemic sclerosis, right? But to understand these autoantibodies, first let us understand the difference between diffuse cutaneous and systemic, limited cutaneous systemic sclerosis, right? Now, there is a table that we should remember specifically, and to make you remember, let us approach this in a very conceptual way, right? So let me tell you that in case of diffuse cutaneous systemic sclerosis, it is a more severe form, and thus the dominant force when we talk about pathogenesis, right? We had this slide discussing the pathogenesis, right? So we started with what? We started with vascular injury and we ended up with fibrosis, right? So in case of diffuse cutaneous, because it is a more severe form, the dominant force of pathogenetic process is mainly fibrosis. In the more severe form, so fibrosis is the dominant force. In case of limited cutaneous, because it is beginning, it is in the milder side, the dominant force is vascular injury, or you can say endothelial injury. With this, let us conceptually address these points. Let us start discussing the skin involvement. This we have already made it clear, right? So in case of diffuse, there is involvement of trunk, and the extremity involvement extends proximal to knee and elbow joints, right? Extends proximal to knee and elbow joint. In case of limited cutaneous, obviously it is restricted to distal portions of knee and elbow joints, right? This is a basic understanding that we have already discussed. Okay. Now, second manifestation, Raynaud's phenomenon. I want you to remember one particular point here. Raynaud's phenomenon in case of limited cutaneous usually predates, or it starts before skin changes. It predates skin changes. In case of diffuse cutaneous, both co-occur or both start together. Okay, this is one point that we should clearly remember, because it helps us to again understand the disease a little better. How? Let me tell you. Okay, see, if Raynaud's phenomenon predates the skin changes, now 5 to 15% of general population may have Raynaud's phenomenon. Okay, so the tendency from the patient side to report these findings to a hospital or to a clinic is little less. I put my hand in cold water, it feels little pale, I do experience little bit of redness and pain. Chalega, it happens, right? But once you start noticing that the skin is becoming thick, you start reporting, right? So because both of them are occurring together in patients with diffuse cutaneous, they may present quite early in the course of the illness when they start noticing skin changes, because Raynaud's phenomenon is also occurring simultaneously. In case of limited, because Raynaud's phenomenon occurs early, the digits are suffering the vascular injury. Raynaud's phenomenon is an outcome of the vascular injury, right? So they may suffer vascular injury, and then they start noticing the skin changes, and then they report, right? So now let us see the next feature. Digital ulcers and critical ischemia. More common in which subvariant? Obviously, because in diffuse cutaneous, both occur together. Raynaud's phenomenon and skin changes, they present early, right? So that is why it is less common. In case of diffuse cutaneous, they are less common. On the other hand, they are quite common in case of limited cutaneous, right? They are more common. So if the MCQ is asking which subtype of the systemic sclerosis is more likely to have digital ulcers and pitting scars on the pulp of the fingers, it is limited cutaneous, right? Which variant is more likely to have critical digit ischemia? Limited cutaneous, right? You can also approach it from the very conceptual thing that we were discussing. Vascular injury is a dominant force in which type? Limited cutaneous, right? That is why all these critical ischemia, digital ulcers are all more common in case of limited cutaneous. Okay. Now coming to musculoskeletal manifestations. Limited cutaneous being a milder side, it only causes arthralgia. It only causes arthralgia. On the other hand, diffuse cutaneous. Okay. So remember, it is the fibrotic process which is the dominant force in case of diffuse cutaneous, right? So that means patients developing inflammatory arthritis, inflammatory arthritis as well as tendon friction rubs are very common in case of diffuse cutaneous, right? So patients can develop arthritis, not just arthralgia, arthritis, and they can also develop tendon friction rubs. Tendon friction rubs. These tendon friction rubs are particularly important because they correlate with the disease activity and they are an outcome of the fibrotic process. So tendon friction rubs are heard because the tendon sheaths are getting adhered to the other fascial structures or the other joint structures, and that is why we are hearing these rubs. So obviously all these are occurring because there is a fibrotic process, right? Because there is a fibrotic process, we see them. So thus they are associated with diffuse cutaneous variant. Now coming to another clinical manifestation, that is pulmonary arterial hypertension. Which subset is likely to develop this? I'm talking about isolated pulmonary arterial hypertension. Yes, if you develop interstitial lung disease, secondary to that, the WHO class 3, you may get, I agree. But isolated pulmonary arterial hypertension is known to occur in systemic sclerosis, and now you should tell me which variant is more likely to get it. Right, obviously, right? Limited cutaneous, because vascular injury is the dominant force on which side? Limited cutaneous, right? Vascular injury is the dominant force on the limited cutaneous. So pulmonary arterial hypertension is more common with limited cutaneous, right? In case of diffuse, it is rare. If it is occurring, it is secondary to interstitial lung disease. Now, interstitial lung disease is also a complication of systemic sclerosis. Now, you should tell me on which side I should place it, right? Which side is the fibrotic process more dominant? Lung disease, ILD is a fibrotic disease, right? So fibrosis is more dominant on diffuse cutaneous, right? So it is more common in cases of diffuse cutaneous. It is rare in case of limited cutaneous, right? So in fact, having anti-centromere antibodies which are associated with limited cutaneous is deemed to be protective of developing interstitial lung disease. Okay, now coming to scleroderma renal crisis. Remember point, 15% of the patients of diffuse cutaneous do experience the scleroderma renal crisis in their lifetime, which is quite rare in case of limited cutaneous sclerosis. Okay, this also conceptually you can remember diffuse cutaneous, there is more extensive involvement, so kidneys are also more affected. Okay, the last one point we should note is about calcinosis cutis. Which variant is more likely to affect? Okay, remember, you can say CREST syndrome as a mnemonic or a synonymous word for limited cutaneous. CREST syndrome. This is kind of synonymous with the limited cutaneous, right? What are the components of the CREST syndrome? C here stands for what? Calcinosis cutis, right? So C here stands for calcinosis cutis, right? R stands for Raynaud's phenomenon. E stands for esophageal dysmotility. S stands for sclerodactyly or skin involvement, and T stands for telangiectasia, right? So CREST syndrome, you can consider it as synonymous with the limited cutaneous, and thus calcinosis cutis is more common in limited cutaneous, right? So these are the points to differentiate. More common in limited cutaneous, less common in case of diffuse cutaneous. Now you clearly understand, right? Conceptually you can apply by just remembering that vascular injury is the dominant force in limited cutaneous and fibrotic process is the dominant force in case of diffuse cutaneous. With that, you can tackle most of the manifestations. Okay. Now, don't write this in your examination because no books describes it that way. This is more of a memory hack for you to remember. Okay. Now, let us understand the antibodies. Okay. See the first antibody that we are talking about. What is the first antibody we are talking about? Anti-topoisomerase 1 antibody. You guys may be recognizing this as anti-SCL70 antibody, right? It is associated with what manifestations? It is associated with tendon friction rubs, interstitial lung disease, and renal crisis, right? Let me look at the second antibody. What is the second antibody we're talking about? Anti-RNA polymerase 3 antibody. It is associated with which manifestations? Tendon friction rub, renal crisis. Yeah, we will talk about the remaining two manifestations. But now tell me, like, these antibodies are likely to be associated with which subvariant of scleroderma? Is it limited or diffuse? Right, it is associated with diffuse, right? So these two are associated with diffuse cutaneous variant. Right? So if there is a question asking you which antibodies are associated with diffuse cutaneous, it is anti-SCL70 or anti-topoisomerase 1 and anti-RNA polymerase 3. Right? These are classically associated with diffuse cutaneous. Now if you look at the next antibody, that is anti-centromere antibody, right? Anti-centromere antibody. If you look at its clinical association, it says digital ischemia, calcinosis cutis, isolated pulmonary arterial hypertension and primary biliary cirrhosis. So which subvariant this antibody is likely to be associated with? Right. This antibody is likely to be associated with limited cutaneous variant. Right. Let us look at the next antibody, anti-PM-SCL antibody, which is also associated with calcinosis. So which subvariant it is more likely to be associated with? Right. Limited cutaneous. Right. Now I want you to note some specific points about these antibodies which have been asked in the past as an MCQ. Let me make the first one. Increased malignancy risk. Now remember, scleroderma is considered as a pre-malignant condition and various malignancy risk is increased. So it is not only restricted to one malignancy. The risk of developing carcinoma of the lung, risk of developing carcinoma of the stomach, risk of developing B-cell lymphomas, right? And various other tumors is increased. And presence of this RNA polymerase 3, antibodies against this RNA polymerase 3 is considered as a risk factor. Right? So this is one MCQ which has already appeared in the past. Apart from that, gastric antral vascular ectasias, again they correlate with anti-RNA polymerase 3 antibodies. The risk of GAVE correlates with anti-RNA polymerase 3 antibodies. Okay. Similarly, they have also asked an MCQ about which antibody correlates with the myositis. So remember, in case of systemic sclerosis, patients can develop both non-inflammatory polymyopathy, polymyositis. They can also develop the inflammatory myositis and the non-inflammatory myopathy. Myositis correlates with this anti-PM-SCL antibodies, and to make it easier for you to remember, just note that this has PM. You can just mentally assume it as polymyositis, and that correlates with the risk of myositis. Okay. Now I have also listed two more antibodies, anti-U3-RNP, which is also known as antifibrillary antibodies. Antifibrillary antibodies and anti-U11-U12-RNP. Right? These antibodies can be seen in both limited cutaneous as well as diffuse cutaneous variants. Okay, so to summarize, which antibodies are associated with the diffuse cutaneous? Classically, anti-topoisomerase 1 or anti-SCL70. The second one is anti-RNA polymerase 3. Right? Two additional points to note about anti-RNA polymerase 3 is it is associated with increased malignancy risk and it is associated with gastric antral vascular ectasias. And if you look at the monitor, you will notice that I am not talking about ILD risk in case of RNA polymerase 3. SCL70 is associated with ILD risk, but RNA polymerase 3, though it is classically associated with diffuse cutaneous variant, it doesn't bring in extra risk of developing interstitial lung disease. Right? There was one MCQ about this point, that's why I'm trying to make this out. Okay. Now, which antibody is associated with the myositis? That is anti-PM-SCL antibodies. Polymyositis, myositis. Okay. If you remember that, I think that's more than enough. Yeah. I also have to tell you about anti-centromere antibodies, which is associated with limited cutaneous, right? Classical thing. Now, those who get confused which one is associated with limited and diffuse, I'll also give you a simple memory hack. What is the hack? Anti-centromere. That means centromeres, right? So they are going to occupy a very minimal space inside the nucleus. Limited space inside the nucleus, limited cutaneous. Now, for those who get confused between antibody association of diffuse cutaneous and limited cutaneous, let me try to make it little simple for you. Okay. So here is an important memory hack. Now, centromeres, where are they present? Part of the chromosomes, right? So they are occupying very limited space inside the cell. Right? Centromeres are occupying very limited space inside the cell. So if you remember that, you remember limited cutaneous is associated with anti-centromere antibodies, right? Limited cutaneous is associated with anti-centromere antibodies. And in case of diffuse cutaneous, what antibodies are associated with? Anti-topoisomerase 1 is one, and the other one is anti-RNA polymerase 3. Right? So DNA and RNA, remember, they are definitely there inside the nucleus in the chromosome, but they are also present in the cytoplasm. They can also be present in the mitochondria, right? So DNA and RNA are more diffusely distributed. Right? So with this, you can remember which one is associated with diffuse cutaneous variant. Right? So I hope I have helped you to remember these points. Diffuse cutaneous, anti-topoisomerase 1, which is also known as anti-DNA topoisomerase 1, or also known as anti-SCL70, and anti-RNA polymerase 3. Diffusely distributed. Right? Anti-centromere, limited occupancy inside the cell, they are associated with limited cutaneous. Anti-PMSCL, associated with myositis. Right? Okay, now with this, let us move to the clinical manifestations. What are the clinical manifestations? Skin is the most commonly involved organ, right? Skin is the most affected organ. What are the manifestations of the skin involvement? Skin thickening is the classical manifestation, but before skin thickening becomes evident, in case of limited cutaneous, there may be evidence of Raynaud's phenomenon. In case of diffuse cutaneous, both may occur together, right? Skin thickening and Raynaud's phenomenon. Thus, Raynaud's phenomenon is seen in both limited cutaneous as well as diffuse cutaneous variants, right? Limited as well as diffuse cutaneous. Okay, one important point we should remember is this limited cutaneous variant patients, because Raynaud's phenomenon predates the onset of skin changes by months to years, right? If they present during that period when they don't have skin thickening and the systemic manifestations, but they have Raynaud's phenomenon, it creates a diagnostic challenge, because 5 to 15% of the normal population may also have Raynaud's phenomenon. Then we call it as primary Raynaud's disease, right? In that case, yes, it becomes an important challenge to distinguish between these two. What helps us to distinguish between these two is nail fold capillaroscopy, right? So remember, this is becoming an important area for MCQs these days. So I want you to remember about it. Nail fold capillaroscopy helps us to distinguish between primary Raynaud's disease and secondary Raynaud's phenomenon. Okay, how does it help? We will discuss more about it. Now, other than skin thickening, we can also notice calcinosis cutis, calcium deposition in the skin, and the pulp of the digits or pulp of the fingers are the most commonly affected sites. Okay, that is the most common site where there is calcium deposition. Other than that, yes, patients can develop telangiectasias, and telangiectasias more commonly affect face and lips. These are the most common sites. These are the most common sites for telangiectasia. And the involvement of face gives rise to some characteristic facial appearance known as mask of faces. This is also an MCQ point. They can directly ask you in which of the following condition we see mask of faces. That is systemic sclerosis. Right? So with this understanding, let us go through some images. These are particularly important images because image-based questions can appear from this. What do we see in the first image? We can clearly appreciate the presence of skin thickening, right? We can appreciate the skin thickening. In this case, it is almost extending. I can notice that it is extending beyond the wrist joint, right? Almost the visualized field, there is skin thickening. Apart from that, patients can develop the digital ulcers. The digital ulcers can be because of the fibrotic process or can be because of the vascular injury. What we are seeing in this image is basically because of the fibrotic process. Right? Apart from that, the pulps of the fingers and the tip of the fingers may have vascular ulcers, and those ulcers may heal with formation of pits. So multiple pits on the tip of the finger and the pulp areas is very common to see, right? And what we see in the next image, we can notice clearly that there is skin thickening, and this skin thickening is almost extending up to metacarpophalangeal joints, right? Skin thickening extending up to metacarpophalangeal joints. And in fact, according to the current ACR-EULAR classification criteria, this may be sufficient for the diagnosis of systemic sclerosis or classification of the case as systemic sclerosis. Okay. Now, additional point you can notice is that there is fixed flexion deformity. Because of the skin tightening, there is fixed flexion deformity, which is also a known finding. Okay, now with this, let us take the next image. What do we see here? We see a characteristic skin depigmentation in the form of multiple punctate spots, because there is depigmentation sparing the area around the hair follicles, right? And this is what is known as salt and pepper appearance of the skin. Salt and pepper appearance of the skin. And you can see one more image where you can appreciate the salt and pepper appearance, right? So this can also be an area for image-based questions. Now, what do we see in this image? In this image, we can appreciate that there is calcinosis cutis. Calcinosis cutis. C of our CREST syndrome, right? I have already told you the pulp of the fingers is the most common affected site, and we can notice it here, right? Then, now let us see this image. What do we notice? Anything striking here? If you notice the distal phalanx, right? There is resorption of the bone, right? There is bone resorption, right? This is what is known as acro-osteolysis or acral osteolysis. The distalmost portion, the bone is lost. So the fibrotic process and the vascular injury and ischemia causes the tissue loss, and it also exceeds to involve the bone. So there is bone loss. That is what we know as acro-osteolysis. This acro-osteolysis is not a finding which is exclusive to systemic sclerosis. There are various other disorders where we can see acro-osteolysis. Any examples? Right. We can see this also in patients with hyperparathyroidism, where we classically describe the entity as the radiological finding as arrowhead appearance. Arrowhead appearance. Right? And not to be confused, don't confuse this arrowhead appearance of hyperparathyroidism with the spade phalanx sign that we see in case of acromegaly, right? In case of acromegaly, don't get confused between these two. Okay. You can also notice certain additional finding here. What do we notice here? What do we notice here? Yes, we can also notice that there is calcinosis cutis. Right? The skin calcification is also evident on this X-ray. Okay? So these are the cutaneous manifestations. Apart from that, in this image, you can appreciate that there is telangiectasia. I have already told you the most commonly affected site for telangiectasia is basically face and lips, right? So we can appreciate in these two images the telangiectasia of the face and lips. Okay. Now, what do we see in this image? What we notice here is what is exactly known as Moscow facies, right? So the characteristic findings in the Moscow facies is number one, the nose becomes pinched, becomes sharp and appears like a bird beak, right? A bird beak nose, right? You can clearly notice in this image, the nose has become sharp. Right? It is like pinched from both the sides and it has taken the appearance of the bird beak, right? Pinched sharp nose, which has taken the appearance of a bird beak. Right? That is one finding of the Moscow facies. Second thing we can notice is microstomia, right? Microstomia, mouth becoming narrow and difficulty in opening. Right? The other thing we can notice is the skin becomes taut and there may be loss of wrinkles. I do agree that in some of the patients, there may be accentuation of the wrinkles around the oral aperture and the angle of the mouth. Right? There may be more wrinkles in that area, but the other areas of the face, the skin becomes very taut and the wrinkles may be lost in that case. Right? You can appreciate that there are no wrinkles in these areas for her age. Right? So that is what is known as Moscow facies. Moscow facies, one important MCQ point. Okay, from skin changes, let us move to the musculoskeletal manifestations. What are the musculoskeletal manifestations? Arthralgia is the most common complaint. Right? Arthralgia is the most common complaint. Right? We already know that in case of limited cutaneous, probably the musculoskeletal involvement is restricted to arthralgia. But in case of diffuse cutaneous, they can develop inflammatory arthritis. And the inflammatory arthritis in diffuse cutaneous kind of mimics the other inflammatory arthritis. So patients can have early morning stiffness. These patients can have early morning stiffness, usually lasting more than 30 minutes. And they can have their symptoms worse in the morning. And as they progresses, as they put the joints into action, the symptoms may get better. And the classical description of inflammatory arthritis. Right? The joints that are commonly involved includes proximal interphalangeal joint and metacarpophalangeal joints, MCP and proximal interphalangeal joint. So there is no involvement of the distal interphalangeal joint. Okay. But something that helps us to distinguish this from the rheumatoid arthritis is the characteristic involvement of wrist and ankle, which are not so common in case of rheumatoid arthritis. Right? So involvement of wrist and ankle is not so common in case of rheumatoid arthritis. Right? Okay. Other than that, we already know that patients can develop tendon friction rubs, which more correlates with the diffuse cutaneous variant. Right? These patients may develop proximal myopathy, and the proximal myopathy may be in the form of non-inflammatory myopathy, or it can be inflammatory. Non-inflammatory, or it can be inflammatory. In case of non-inflammatory, the complaint is in the form of proximal muscle weakness, but the CPK levels will be normal. In case of inflammatory, obviously there is inflammation, there is myositis, so CPK levels would be raised, right? And this inflammatory characteristically more associated with the diffuse cutaneous variant, right? Diffuse cutaneous variant. And what additional thing we know is that it may be associated with presence of anti-PM SCL antibodies. Now I know there is some description in my description of this discrepancy there. That is because anti-PM and SCL antibodies are more characteristically associated with the limited cutaneous, but its presence is associated with the increased risk of developing inflammatory myositis in patients with limited cutaneous, right? Other than that, diffuse cutaneous patients are more likely to develop the inflammatory myositis. Okay. The other thing, another musculoskeletal manifestation is carpal tunnel syndrome. That is also more commonly seen in diffuse cutaneous variant. Okay. Fibrotic process we are talking about, right? Okay. That's all about the musculoskeletal complaints. Now coming to CVS. CVS, almost any part of the heart can be involved. Patients can develop pericarditis. Patient can develop myocarditis. Myocarditis may go on to cause heart failure, and there may be certain heart blocks also. But in majority of the patients, the cardiac manifestations are silent. If you use very sensitive tools or invasive testing, you may unearth all these diagnoses. But in most cases, the cardiac manifestations are usually silent, right? Evident or obvious clinical cardiac disorder is rare in case of systemic sclerosis. Okay. Now coming to GIT involvement, right? Probably this is the second most common organ affected after the skin, right? This is the second most common organ affected, or the system affected, I should say, right? So it can involve any part of the GIT, starting from the oral cavity to the rectum. It can involve any part of the GIT. If you see what is the oral cavity involvement, we already know it can cause xerostomia, it can cause microstomia and xerostomia, right? So mouth, dryness of the mouth is a common complaint, and difficulty in opening the mouth because of the microstomia is a common complaint. If you see what is the involvement of esophagus, it can cause GERD, and this is one of the difficult to treat GERD symptom. Patients with systemic sclerosis, if they develop GERD, it is a bit difficult to treat in comparison to the general GERD cases. Then if you look at the liver involvement, it can be associated with primary biliary cirrhosis, right? And if you talk about the involvement of stomach, two things can occur. Patients can develop gastroparesis. Again, that will be a difficult to treat gastroparesis. And patients can also develop gastric antral vascular ectasias, GAVE, what we recognize as by its characteristic endoscopic finding, watermelon stomach, right? Watermelon stomach. So remember, this is one of the important reasons for anemia in patients with systemic sclerosis. Yes, they are prone to develop the anemia of chronic disease. All rheumatological disorders are associated with anemia of chronic disease. But systemic sclerosis, there is an additional important contributor, that is bleeding from the GAPE, right? So these gastric antral vascular ectasias can bleed, and they can contribute to the development of anemia. Right. So all patients of systemic sclerosis, when they have anemia, they should be screened endoscopically for presence of GAPE. And we already know which antibody correlates with the presence risk of gastric antral vascular ectasias, right? The antibody that correlates is anti-RNA polymerase 3, right? So this antibody correlates with the risk of gastric antral vascular ectasias. If you move further down, intestinal involvement may be in the form of diverticulae, right? Patients can develop intestinal diverticulae. Patients can develop constipation as well as diarrhea, and they are also prone, because of the chronic constipation, they are prone to develop rectal prolapse. So point to note about the GIT involvement, this is the second most commonly affected organ, seen in almost 70% of the patients. Both the involvement occurs in both limited cutaneous as well as diffuse cutaneous, right? And any part of the GIT can be affected. Particularly, I want you to remember the gastric vascular antral ectasia, where there is a very strong association, and there is very strong association with the GERD. Okay. Now coming to the involvement of the lungs, right? The most common affected organ is skin. The second most common affected organ is the GIT, but the most common organ responsible for deaths is lungs, right? So the most common cause of death in patients with systemic sclerosis is basically the involvement of lungs, which occurs in the form of interstitial lung disease as well as pulmonary arterial hypertension, right? We already know interstitial lung disease is more common in diffuse cutaneous variant, and isolated pulmonary arterial hypertension is more common in limited cutaneous variant, right? If you have to specifically pick up what is the most common cause for death, then ILD is responsible for more deaths these days than pulmonary arterial hypertension, right? As an organ, lung is the most common organ affected that is responsible for death, and ILD is the most common cause for death. Okay. Now talking about the interstitial lung disease in these patients. Yes, it is more common in diffuse cutaneous variant, and both types are known to occur, NSIP as well as UIP. And obviously it is the UIP variant which is associated with a bad prognosis. If you talk about the risk factors for developing interstitial lung disease, Okay, let me tell you one important point. If you randomly do HRCT or do the lung biopsy of all patients with systemic sclerosis, you will notice that majority of them have some degree of fibrotic changes. But it doesn't matter to us as long as it is non-progressive, right? So a reasonable chunk of these patients develop the progressive interstitial lung disease. And the risk factors that are associated with the progressive interstitial lung disease include male sex and Black American race, or you can say blacks, male gender and blacks. Other than that, having these antibodies, right? Anti-topoisomerase 1 antibodies or anti-SCL70 antibodies are associated with increased risk. The other antibody that is seen in diffuse cutaneous RNA polymerase 3 is not associated with the increased risk of interstitial lung disease. And also it is assumed that presence of anti-centromere antibodies, right? Anti-centromere antibodies may be protective for the risk of developing interstitial lung disease. But if patients with anti-centromere antibodies develop the interstitial lung disease, it is going to be more severe, right? So what point I'm going to say? Anti-centromere antibodies, that presence is kind of protective against the development of interstitial lung disease. But despite having anti-centromere antibodies, you develop interstitial lung disease, this is going to be more severe than patients who have a negative anti-centromere antibodies, right? Okay. Now coming to pulmonary arterial hypertension. This is usually defined as mean pulmonary arterial pressure more than 25 millimeters of mercury with a capillary wedge pressure less than 15 millimeters of mercury. So that means for definitive diagnosis, we need a cardiac catheterization, right? Going by the definition. Isolated pulmonary arterial hypertension is more common in limited cutaneous. Secondary to interstitial lung disease, yes, patients with diffuse cutaneous also can develop the pulmonary arterial hypertension. That is called as WHO class 3. That is more to do with the diffuse cutaneous variant. In case of the limited cutaneous, more common is isolated pulmonary arterial hypertension, right? What are the risk factors? The risk factors include having this anti-centromere antibodies, right? The antibodies that are protective of ILD risk are increasing the risk of developing isolated pulmonary arterial hypertension. Anti-centromere antibodies. Other than that, anti-U3-RNP, which is also known as anti-fibrillary antibodies, and anti-U1-RNP, which is characteristically seen in patients with mixed connective tissue disorder. All these are associated with increased risk of developing pulmonary arterial hypertension, right? Now, coming to the other organ involvement. The brain is characteristically spared in patients with systemic sclerosis. And if at all we have to talk about the neurological involvement, there may be some cases of autonomic and trigeminal neuropathies, right? So the most common cranial neuropathy that is seen in patients with systemic sclerosis was once upon a time an MCQ in PGI, that is trigeminal sensory neuropathy, right? The point I want you to remember, it is mainly affecting the sensory component. It's a trigeminal sensory neuropathy and presence of anti-U1-RNP antibodies, right? The antibodies that are characteristically associated with mixed connective tissue disorder, right? They correlate with the risk of developing trigeminal sensory neuropathy, anti-U1-RNP antibodies. Patients can also develop, as I told you earlier, can develop autonomic neuropathy. So that is the neurological manifestations, right? And we have already discussed that anti-RNA polymerase 3 antibodies are associated with the risk of malignancy. So what malignancy risk is increased? The risk of carcinoma of the lung is increased. Carcinoma of the stomach is increased. Risk of lymphoma is increased, and overall the risk of other malignancies is also increased, right? Overall the risk of other malignancies is also increased, right? Before we move on, just let me jot down the connection between anti-RNA polymerase 3 antibodies. Right? They are associated with a very high risk of developing malignancies. Okay, now coming to the most important organ involvement. From there, MCQs are repeatedly being asked, that is scleroderma renal crisis. In the past, before the advent of ACE inhibitors, this was the leading cause of mortality, right? But once the ACE inhibitors came into picture and we understood the pathophysiological mechanisms underlying the scleroderma renal crisis, this contribution towards mortality has drastically reduced, right? Mortality figures have improved greatly. What is scleroderma renal crisis? Basically, it is a high renin state, right? It is a high renin condition or high renin state where patients present with new onset hypertension or rapid worsening of pre-existing hypertension. Keeping the age in mind, most of the patients wouldn't have been diagnosed as hypertension by the time they present. So most cases, the most common presentation of scleroderma renal crisis is a patient of scleroderma presenting with new onset hypertension, right? That is the most common presentation, new onset hypertension, right? And for the diagnosis, we need to prove that patient has systemic sclerosis or scleroderma and has the new onset hypertension and also has renal insufficiency. So presence of renal insufficiency is considered as an essential component of the diagnostic criteria. Right? So there are various diagnostic criteria regardless of what you follow. Presence of new onset hypertension or a rapidly worsening hypertension plus renal insufficiency are considered as essential for the diagnosis. Okay. I want you to remember certain additional points. The additional points are these. 15% of the cases, especially the diffuse cutaneous variants, experience scleroderma renal crisis in their lifetime. 15% of the patients with systemic sclerosis experience scleroderma renal crisis in their lifetime. More so with diffuse cutaneous variant, right? And also remember, the risk is maximal in the first 4 years of the symptom onset. After that, the risk exponentially decreases. More than 85 to 90% of the cases are diagnosed as having scleroderma renal crisis in the first 4 years of the onset of their initial symptoms. After that, it is very minimal risk, right? Okay. Now coming to its diagnosis. And now there are various diagnostic criteria. The one I am putting out here is the UK Scleroderma Study Group criteria for renal crisis. So this has two components. The first one is the essential criteria. What are the essential criteria? The number one essential criteria is new onset hypertension, defined as BP more than 150 by 85 millimeters of mercury, or a systolic rise over and above the baseline by more than 20 millimeters of mercury. And this should be sustained for at least 24 hours. Right? So the two readings taken 24 hours apart still agree with this observation of BP more than 150 by 85 millimeters of mercury or a rise of 20 millimeters over the baseline systolic. That is the first essential criteria. I've already told you the second essential criteria is some form of evidence of renal insufficiency. Most of the guidelines follow the acute kidney injury. Right? In the UK Scleroderma Study Group, AKI stage 1 or higher, which can be defined as more than 50% increase in the serum creatinine from the stable baseline. Right? These are the essential criteria. Apart from that, yes, there are certain supportive criteria. What are the supportive criteria? Patient may be having microangiopathic hemolytic anemia on the blood film or evidence of that in the form of thrombocytopenia or other cell cytopenias, or in the form of biochemical findings consistent with the hemolysis. Right. Then findings consistent with accelerated hypertension on retinal examination, fundoscopic findings of accelerated or malignant hypertension. So when you do blood vessel biopsy or when you do fundoscopy, right, this characteristically resembles the malignant hypertension changes, because this is nothing but a malignant hypertension itself occurring in the backdrop of scleroderma, right? Because of the renal involvement, you may have microscopic hematuria or frank blood on the urine microscopy. Patients can develop oliguria or anuria. So that is one of the point to note. And if you do the renal biopsy, you may see onion skin proliferation within the walls of the intrarenal arteries and arterioles, something characteristically seen in malignant hypertension, right? Fibrinoid necrosis and glomerular sinkage, and a sudden presentation in the form of flash pulmonary edema. These are all considered as supportive evidence. Essential components: new onset hypertension and acute kidney injury. Supportive evidence are all these: microscopic hemolytic, microangiopathic hemolytic anemia, then findings of accelerated hypertension on the retinoscopy, right, oliguria or anuria, then microscopic hematuria, and renal biopsy consistent with the malignant hypertension, changes in the vasculature, right. So this is the diagnostic criteria. Treatment part we will discuss as we discuss the treatment of the scleroderma per se. Okay. Now coming to the diagnosis of scleroderma. Yes, I do agree that mostly we diagnose it based on the clinical context, but physicians have a tendency to follow the classification criteria for the diagnosis also, because it makes it a little more easier to approach the case. So what is the classification criteria that is currently prevalent? We have 2013 ACR or EULAR classification criteria. Okay, so in this criteria, if patient scores 9 or more than 9, it is classified as systemic sclerosis, right? So there are 2 or 3 important MCQ areas that I want you to remember. Area number 1, something called as sufficient criteria, right? Something known as sufficient criteria. What is sufficient criteria? Okay, skin thickening of the fingers of both hands, right? Please pay attention to the wordings. Skin thickening of fingers of both hands. That means bilateral fingers, skin thickening, extending up to metacarpophalangeal joints, right? Extending up to metacarpophalangeal joints. This is known as sufficient criteria, right? If this criteria is met, that gives the 9 points to patient, and that alone is enough for the diagnosis classification of the case as systemic sclerosis according to the ACR-EULAR 2013 criteria. This is exactly what is known as sufficient criteria. Okay, skin thickening which does not meet this criteria is also a component of the classification criteria, and that also gets some score, right? Then the lesions on the finger tip in the form of tip ulcers or pitting scars. We have already discussed patients may develop tip ulcers and it may heal with the pitting scars. That is also a component of the classification criteria. We know that patients may develop telangiectasia, especially involving the face and lips. That is also a component of the classification criteria. Then we were talking about this nail fold capillaries, right? That helped us to distinguish between the Raynaud's disease versus secondary Raynaud's phenomenon. Yeah. So in case of secondary Raynaud's phenomenon, we see abnormal nail fold capillaroscopy findings. So abnormal nail fold capillaroscopy findings also gets a score on classification criteria. Yes, Raynaud's phenomenon is also a component, and nail fold capillaroscopy is also a component. And obviously having the lung involvement in the form of pulmonary arterial hypertension or interstitial lung disease also qualifies. Right. And then obviously the antibodies, right? The antibodies that are characteristically seen in diffuse cutaneous, anti-SCL70 and anti-RNA polymerase 3, and the ones that are characteristically seen in limited cutaneous, anti-centromere antibodies, right? So this presence also gets some score on the scoring system. 9 or more than 9 is sufficient to classify the case as systemic sclerosis, and that can be purely satisfied by just having the skin involvement extending up to metacarpophalangeal joints involving both hands, right? That is why we call it as sufficient criteria, and they can ask you what is the sufficient criteria. Okay, that is about the classification and diagnosis. Now coming to management. Okay, when it comes to management of systemic sclerosis, right, unlike rheumatoid arthritis or say SLE, I don't have one blanket drug which I can say you can give it to anybody as a blanket treatment. We don't have it because certain important links in the pathogenetic process are not well understood. We know that transforming growth factor beta and other fibrogenic cytokines play an important role in the fibrosis process, right? But the preceding events are not clearly well elucidated. So the targets available for treatment are limited. Yes, there are studies which have seen various drugs as for their anti-fibrotic process, but they have not yielded good result, right? For example, many doctors continue to prescribe D-penicillamine with the hope that it exerts some kind of anti-fibrotic properties, but studies have clearly shown that it is not helpful. Right? Then also studies have shown that use of steroids is not helpful. Right? So right now there is no drug which can be used for its immunosuppressant or anti-fibrotic properties. Right? So what we do when we have a diagnosis of systemic sclerosis, we have to do the most important thing is, or I can say the first step in the management is to do antibody profiling and clinical profiling. And that makes an important impact on the management. So classify them as having either limited cutaneous or diffuse cutaneous based on the clinical profile and antibody profile. Right? And also make a list of the antibodies that are abnormally found in those patients, because we know antibodies are associated with certain clinical outcomes. We know these subvariants are associated with certain clinical outcomes. So we can customize the treatment plan according to that, right? We can target what are the possible or anticipated complications in those patients, right? For example, if you diagnose someone as having diffuse cutaneous and you know that he is anti-SCL70 positive, now we know that he is at increased risk of interstitial lung disease, so we can have a tailor-made follow-up plan for him to predict or to identify the interstitial lung disease at the earliest, and once we identify at the earliest, to prevent the progression of interstitial lung disease, we do have some drugs, right? There are anti-fibrotic drugs which can be used. Similarly, if it is diffuse cutaneous, we also know that he is at risk of developing the scleroderma renal crisis. So we can educate the patient to identify the signs of hypertension, maybe self-monitoring of the blood pressure and early reporting. And that could be life-saving, right? That is our approach. So the most important step is the clinical and antibody profiling of the patients. Once you do that, then we know what are the complications to look for and identify the complications early and then treat them according to the standard conventional treatment, right? So if the interstitial lung disease is encountered, how do we treat? We have anti-fibrotic agents like nintedanib, and we also have another anti-fibrotic agent called as pirfenidone, right? These can be used, pirfenidone and nintedanib. American College of Rheumatology and EULAR backs the use of cyclophosphamide in patients with rapidly progressing interstitial lung disease. So this can also be used. Okay. Then if patient has developed pulmonary arterial hypertension, what can we do? We can prescribe them bosentan. We can prescribe them phosphodiesterase inhibitors like sildenafil. Personally, I prefer to use mainly tadalafil because of its longer duration of action and the OD dosing. But nonetheless, because of the patient's convenience, you can use whatever is comfortable, he is comfortable with. You can choose either sildenafil or tadalafil. Right. Other than that, yes, you can also use the newer drugs like selexipag and riociguat. These can also be used. Okay, that is our approach to pulmonary arterial hypertension. Obviously, we have to screen for it, and when in doubt, or patients presenting with exertional dyspnea, especially the FVC by DLCO ratio out of proportion to the FVC decline, right? In those cases, we have to be watchful, maybe subject them for the cardiac cath lab studies, diagnose them early and start treating. Okay, GERD is one of the difficult to treat symptoms. We usually follow PPIs and prokinetics. Very often we need to experiment with individual agents to see what works well for the patient, and maybe a combination of PPIs and prokinetics. Now, gastric antral vascular ectasias, because of their bleeding tendency, right? If there is anemia present, we should screen for that, and if they are bleeding, then we have to treat them with endoscopic therapy, right? Endoscopic treatment. Okay. Other than that, Raynaud's phenomenon is a manifestation, right? How do we treat? What can we do for treatment of Raynaud's phenomenon? Yes, we can use calcium channel blockers, right? Calcium channel blockers are the drug of choice for treatment of Raynaud's phenomenon. Then coming to scleroderma renal crisis. Scleroderma renal crisis. When do we suspect and how do we treat, right? We would suspect a patient with systemic sclerosis presenting with new onset hypertension plus having renal insufficiency, right? That qualifies for the diagnosis. And once the diagnosis is established, what is the drug of choice? Because this is a high renin state, right? Because this is a high renin state and most of the manifestations are because of the malignant hypertension. Our initial drug of choice is an ACE inhibitor, right? A rapid acting ACE inhibitors. That is our initial drug of choice. Okay. If that is not like maximally tolerated dose of ACE inhibitors is not helping to achieve the good BP control, you can add ARBs or calcium channel blockers. Okay. By the time the patient presents, a good number of patients may require support in the form of hemodialysis. But remember, more than 50% of the patients who go on to require hemodialysis make a recovery from the dialysis requiring state. Right? The remaining number of patients may become dialysis dependent. The more earlier we diagnose and institute ACE inhibitor therapy, chances of requiring or progressive renal insufficiency is less, right? Okay, so that is about the scleroderma renal crisis management. Now, before we wind up, let us also understand a little bit about Raynaud's phenomenon, because again, I do sense important MCQs coming from this topic. Okay. Raynaud's phenomenon can be divided into two broad categories, the primary Raynaud's phenomenon and secondary Raynaud's phenomenon. So in case of primary Raynaud's phenomenon, it is not associated with any other disease. Secondary Raynaud's phenomenon is where the other disease is responsible for patients experiencing Raynaud's phenomenon, right? So primary Raynaud's phenomenon is also known as Raynaud's disease. Raynaud's disease. Okay. Now what happens in Raynaud's disease? In Raynaud's disease, there is exaggerated physiological response to cold. Physiological response to cold. Okay. Now, what happens when there is someone experiencing Raynaud's phenomenon? They're basically experiencing certain symptoms. What are those? When they're exposed to cold, the first thing that they notice is the hands or acral parts are becoming pale, or paler is the first initial manifestation, and that is because of the vasoconstriction, right? Vasoconstriction on exposure to cold causes pallor. After that, because there is vasoconstriction and it is sustained, patients develop cyanosis. So it starts with pallor, then they develop cyanosis, and once the vasoconstriction resolves, right, there is rebound perfusion of the affected areas, and that leads to hyperemia. So it starts with pallor, goes to cyanosis, then becomes hyperemic, and during these periods, patient may also experience pain to some extent, and then it resolves. Right? Especially exposure to warmth causes the resolution. In patients with Raynaud's disease, the normal response to cold is exaggerated, and that is why they are experiencing all these changes, right? So we don't have any vascular abnormality. So there are no abnormal vascularity, right? That is Raynaud's disease. In case of secondary, it could be secondary to connective tissue disorders, right? And when we talk about connective tissue disorder, I think that the first thing that should come to our mind is obviously systemic sclerosis. Other than that, patients with SLE, rheumatoid arthritis, they all can experience various connective tissue disorders. Patients can experience Raynaud's phenomenon. Now, this primary Raynaud's phenomenon or Raynaud's disease, where there is physiological exaggeration of response to cold, is seen in 5 to 15% of the general population. It is seen in 5 to 15% of the general population. And that is why it is very important for us to distinguish between the Raynaud's disease versus secondary, right? I have already told you that there are no abnormal vascularity, so we are expecting the nail fold capillaroscopy, the test that is done to distinguish between these two types of Raynaud's phenomenon, is going to be normal, right? Normal. In case of secondary Raynaud's phenomenon, the Raynaud's phenomenon is because of the vascular destruction, and thus the nail fold capillaroscopy will be abnormal. Now you should tell me, what do we expect in case of systemic sclerosis? The nail fold capillaroscopy will be normal or abnormal? Obviously, right? It is going to be abnormal. Right? So let us go through some important images of the nail fold capillaroscopy. What do we do in nail fold capillaroscopy? We, under the light microscope, examine the nail fold. We put a drop of oil immersion microscopy, and now yes, there are more advanced digital devices, handheld devices, and even devices which can be coupled to the mobile phones are available. Well, any of them, whatever you follow. Basically, we are looking at the capillaries in the nail fold. Right? So in a normal patient, when there is no vascular injury, capillaries are arranged in an orderly fashion. Right? Capillaries, it would look like this. Capillaries are arranged orderly, right? And they have a uniformity in terms of size. You can see in the image number 1 here. It is a normal nail fold capillaroscopy. You can see a lot of capillaries. All of them kind of look same, right? In terms of morphology, they look same, and they're little neatly arranged. Obviously, the angle of weaving might give a little bit of distorted look, but they're all neatly arranged. That is how normal would look like. From this, once there is vascular injury, right, the earliest change that we can appreciate on nail fold capillaroscopy, one important MCQ point, the earliest or the first finding, that is giant capillaries, right? So in early stage, we can notice that capillaries are becoming, in response to vascular injuries, there is increased proliferation and capillaries are becoming more larger in size, right? That is what we call as giant capillaries. So giant capillaries is the earliest nail fold capillaroscopy sign in patients with secondary Raynaud's phenomenon, right? This is an MCQ point. And as the condition progresses, we start noticing that there may be multiple hemorrhagic spots here and there in the nail fold. And other than that, you may start noticing that the fibrosis is kicking in. There is distortion of the architecture, and there are multiple areas where there are no capillaries present at all. We call them as avascular areas, right? You start noticing that there are avascular areas, right? And as the condition progresses further, there may be angiogenesis, so new capillaries may be being formed. They definitely don't resemble morphologically the normal capillaries that we see, right? The normal capillaries that we see here, they don't resemble that. Right? They are more haphazardly growing. New vessels being formed, angiogenesis. So remember, in case of Raynaud's disease, we see normal nail fold capillaroscopy, and in case of secondary Raynaud's phenomenon, we see abnormalities. The abnormalities include giant capillaries. Then the second abnormality is there may be avascular areas. There may be fibrosis and distortion of the architecture, and there may be angiogenesis or new vessel formation, right? These are the abnormalities that we see. And remember, these abnormalities, if found on the nail fold capillaroscopy, is also a component of the classification criteria for systemic sclerosis. Patient gets 2 points if the nail fold capillaroscopy is abnormal, right? Okay. With that, we'll wind up for now, guys. Before I wind up, let me tell you, remember the differences between limited cutaneous and systemic, the diffuse cutaneous systemic sclerosis. Be aware about the antibodies and their associations with the characteristic clinical conditions, and also be aware about the images, right? Image-based MCQs are possible from this segment. Okay, thank you.